Hi, this is Rohit Sham, and today we are going to talk about a very important and common topic that is vertigo. So, vertigo is a false sensation of the moment in the absence of the actual moment. So, that's vertigo. The patient often they complain of the dizziness. The dizziness is actually a non-specific term that provides no meaningful information about what is occurring to the patient. So simply by taking a complete history, it's possible to determine whether the patient is having a vertigo or a presyncope. Because this dizziness with the complaint with the patient is coming, that is could be either vertigo or could be presyncope. So as the vertigo is a false sensation, it could be accompanied by nausea and the vomiting, and it's neurogenic in the etiology. While this presyncope, that is like lightheadedness, feeling like the patient is going to drop, or the patient says that I'm going to black out, and it could be cardiogenic or the neurogenic, depends. Let's now move towards the etiology of vertigo. So for convenience, let's divide it into two, the central and the peripheral. So the central could be either because of stroke, either ischemia or a bleed, a tumor, or the drugs. What drugs? Antimalarials, some of the anti-inflammatories and anticonvulsants, they can cause central vertigo. While the peripheral causes Meniere's, benign paroxysmal positional vertigo, and labyrinthitis. So keep these things in your mind when you are actually evaluating a patient with the vertigo. Now, how you going to differentiate between the central and the peripheral? Then you can move on the either side, depends on it's a central or a peripheral. So there are some differences which you need to look over here. So central vertigo and peripheral vertigo. So central vertigo is gradual in onset, while the peripheral vertigo is sudden in onset. Central vertigo presents with the central symptoms, like the symptoms that occur in a stroke that can present with that, like diplopia, dysarthria, cortical blindness. There could be extremity weakness or numbness. While the peripheral vertigo, it presents with the eight nerve symptoms, tinnitus, and hearing loss. The next thing is that the central vertigo, it's pure vertical and multi-directional nystagmus. There is pure vertical, multi-directional nystagmus, and it does not suppress with fixation. While in the peripheral, it's mixed horizontal, unidirectional nystagmus, which suppresses with the fixation. So these things you can ask the patient, and you can elicit the nystagmus to know that whether it's central or peripheral, and then move towards the causes. Now the treatment, if we move towards the treatment, so for central, it's essentially like fixing the thing, and for the peripheral, for the Meniere disease is actually characterized by a triad of tinnitus, hearing loss, and episodic vertigo, and there's also um, fullness in the ear. Two most common causes of the Meniere disease is syphilis and the head trauma. If we And the treatment for Meniere disease is diuretics and amiclozine. It is an antihistamine, and if this fails, one can consider the surgical decompression. If we move towards the benign paroxysmal positional vertigo, we know that it is vertigo with the head movements or change in the head position, and it lasts for 10 to 60 seconds only. Okay, and what's the treatment? The maneuvers. Okay, one maneuver for confirming the diagnosis, and other is for treating. Okay, Apley's and Dix-Hallpike maneuvers. Okay, now labyrinthitis. Labyrinthitis again, it presents like sudden onset of vertigo. Okay, and the hearing loss and the tinnitus, but it follows an upper respiratory tract infection. And the treatment for that is meclizine, diazepam, and in severe cases, if these two things are not helping, the steroid might help. Thank you.